Good morning, good afternoon, and good evening to all the urology trainees, depending upon which part of the world you are logging in for our YouTube training session on urology exam preparation. We are entering episode 66. In this episode, we are going to conduct a mock exam on various infertility related scenarios. We have our trainee volunteers. Thank you for that. So, can we start the first scenario?
Yes, please.
Okay. Your time starts now. You have a 28-year-old gentleman presented to the clinic to discuss the option of vasectomy. How are you going to discuss with him?
So I'll see this 28-year-old gentleman, preferably along with his partner. I'll take a focused history and also do a clinical examination. In my history, I will ascertain why he wants the vasectomy, and he understands that it's a irreversible process. I will also ask if he had previous, if he had kids before, and has he tried other measures of contraception. I will ask about previous urological history, previous surgical history, any and then in presence of chaperone, I'll do a clinical examination, which involves assessing his general status, examination of his abdomen, examination of his inguinal region, and his genitals, mainly a scrotal region, to look for any scars, obvious abnormalities. And after that, I'll discuss further details of the procedure with him.
What is the importance of looking for scars and extragenitalia examination in this patient?
For planning the procedure, and also planning the incision for the vasectomy, it will be useful to know where the scars are and if I can palpate the bilateral vas.
Okay, so how your incision will differ based upon the previous scars?
So if there is any midline scars or the lateral scars, I in my practice I usually make two different incisions so that I avoid cutting the same vas twice. So the scars will make difference in planning incision.
Okay. What other questions you need to ask him, and how are you going to proceed further?
So I'll ask him whether he has tried the other forms of contraceptive measures. Does he understand that this is an irreversible process? And after the vasectomy, he needs to have azoospermic sample. Usually, it is done at 12 weeks and 16 weeks, making sure that he's azoospermic, and then he will be allowed for unprotected sexual intercourse and declared azoospermic for unprotected sexual intercourse thereafter.
Why you need two samples? Say, for example, if the 12th week sample is azoospermic, you still need 16th week.
If it is azoospermic at 12 weeks, then usually then there is no need, but usually they need to have 20 ejaculates before we declare them azoospermic.
Okay. So how are you going to proceed further? He's quite fit, young, no previous surgeries. He understands whatever you say, and he tried alternative contraceptive methods. He find buying condoms too costly for him.
Uh, okay, then and his partner is in agreement with this.
Yes.
Okay. In this case, I will explain the procedure to him in detail. I will aid my discussion with the BOWS information leaflet, and also discuss the side effect of the procedure. So, procedure involves a procedure under. It can be either under local or general anesthetic. He will have two scars on his scrotum. We will dissect these scars. We will dissect the bilateral vas, isolate it, and remove it. So in my practice, I usually use hemoclips and also cauterize the lumen of the scar and send dissected vas for the histology. I will code the risk involved, which will be infection, hematoma, in very rare cases, chronic in scrotal or testicular pain. I will also code the failure in early stages, one in 300, and in late stages, one in 2000. and I will let him to have a cooling period in between consenting, and to make sure he really wants to go ahead this procedure and he understands this is irreversible, and then I will take him for the surgery.
Why there is a late failure? What is the reason behind it?
So, so late failure happens because of recanalization, and usually it is down to the procedure used to ligate the both ends of the vase.
Okay, so a patient agrees with this. You're giving a cooling period of say 2 weeks time, and he's attending for the procedure. How are you going to take it forward?
So on the day of procedure, I'll reconfirm that he understand the procedure. I'll confirm the consent after WHO checklist under general anesthetic in supine position. I usually palpate the vas on one side, then I do a paramedian incision to the median raphe, isolate the vas from the cord structure between the fingers, then dissect over it. Once the vas is isolated, I dissect at least 1 to 1.5 centimeters of vas segment. Then I divide the vas segment with the hemoclip, divide it with the cautery, and after division, I cauterize further with the electrical handheld cautery, and then close the incision with the absorbable vicryl sutures, usually 3O vicryl, and I repeat the procedure on the opposite side. I send the cut vas segment for histopathology. I do the simple gauze dressing, and then a patient will be usually discharged as a day case.
What is the reason for sending it for histology? You know it's VAS and it should show VAS. So, do you think it will show something pathological? Why?
Uh, so it is important to send the vas segment histologically for medical legal purpose in case there is a very rare chance of recanalization, and if there is any further litigation. So it is ideal to send them both for histological, confirming that we have indeed dissected the vas segments.
Okay. And so, post operatively, how are you going to counsel him? How are you going to follow him up?
So, as I have explained him earlier, he needs to have a form of contraceptive used for further, and I will ask him to produce semen sample at 12 weeks. And make checking for azoospermia, and also if it is not azoospermic, then I'll repeat it at 16 week, making sure that it's azoospermic before I let him allow unprotected sexual intercourse. I'll give him simple analgesic to start with post-operatively that he can use it for 48 hours.
How are you going to counsel him to give the sperm sample? What advice you will give?
So sample should be produced after 3 days of abstinence, preferably in the lab provided container in the lab. If it is produced at home, it should be brought immediately at the room temperature, preferably in shirt pocket, to the lab so that it will be checked.
Why 3 days of abstinence?
To produce to make sure that he has enough semen volume.
Mhm. What are you going to prove in this semen sample? What are you aiming for?
So the objective of this is to make sure that there is azoospermia and vas are ligated. There are some situations where there will be non-motile sperm, and if it is regular samples are not azoospermic, then there is something called special clearance can be done, which happens after usually 7 months.
What do you mean by special clearance?
So, in a situation where there are non-motile sperms after 7 months, usually 100,000 sperms per ejaculate. So, it is not possible to conceive with those non-motile sperms. So, if there are two samples which are showing non-motile sperm less than 100,000 ml of sperms per ejaculate, then patient will be given special clearance.
What is the evidence behind this?
I'm afraid I can't quote the name of the study.
Okay. So this patient, for example, the 12-week sperm sample showed good amount of sperms. Maybe you can label it as oligospermia. So you are repeating it 16 weeks. Again, it is not azoospermic. What will you do?
So at 6, so we'll wait for further 4 weeks and see how if it produces azoospermic sample, uh, and see. I will ask him to produce 2 or 3 ejaculates to make sure that he produces azoospermic sample.
At what point you will decide that the procedure is failed and he's got persistent live sperms?
After 7 months, if it's still persisting live sperms, then I will tell him that unfortunately this there may be a risk of recanalization.
Okay, you said that you will give him special clearance in case if there is only non-motile sperms. Okay, we'll complete with this question.
Yeah.
Does that patient require any follow-up after 7 months?
Usually, if it is he has given a special clearance, then he should come maybe after 4 weeks to produce a semen sample to for a documentation purpose that he still has a non-motile sperm or a azoospermic sperm.
Okay,
Later on.
good. We'll stop there. Good performance, no major concerns. You are quite clear in what you are talking. Some values are very good. Very minor deviations from perfect 8. Okay. For example, you mentioned about GA vasectomy. You never brought in the picture of local anesthesia vasectomy. It is possible. It is done in many centers. There is nothing wrong if you are not doing it, but you should say that there is a possibility of local anesthesia vasectomy, but in my setting I will do under GA. Okay. The other thing is, especially when you're doing under local, sometimes it's easier if we make one small median raphe vertical incision and try to bring the left vas and right vas into the same incision, which is less traumatic to the patient. One local anesthesia which will act better. So that's why if you learn a little bit about local anesthesia, you will also mentally agree the single incision vasectomies. And intraoperatively, there is forceps by name ring forceps, which is almost like a miniature version of the spermatic cord forceps, so that it's easy to hold the vas and try to dissect all the surrounding structures away from the vas so that you will get only the vas in the specimen. And it's very important when you are counseling the patient to know about the previous children in detail. How many children he has, how many children the partner has, how many children they have in common with each other. And you should explain the patient that in case in future, if he needs a reversal, it is not available in NHS. He needs to go for a private service, and even if he goes for a private service, by chance if he depends on insurance, insurance may not cover. It's very important you bring it before vasectomy.
Okay.
And you should mention about the rare possibility of testicular atrophy in case if the vasal artery or the testicular artery is injured, even though it's rare. And then unfortunately your value on special clearance is wrong. It is 10,000 non-motile sperms per ml. Okay, it's 10,000, it's not 100,000. When you review the YouTube video, I will post the exact study, 1990. It is usually called as Canston study, but the first author is Davies, the last author is Mitchell. I don't know why the study has gone in the name of Canston, and it is from Elliot Smith Clinic in Oxford. So that's why it's very commonly called as Oxford special clearance. If you have to give a patient special clearance, the first thing is, as I said, 2 consecutive sperms should show less than 10,000 non-motile sperms per ml, not even one motile sperm. And you should wait at least till 7 months. And then these men should be reviewed with further sperm test for at least 3 years to see whether any live sperms appear in the later life or to prove whether it's azoospermic. Okay, they can't be discharged in 7 months. In 7 months, you can declare them with special clearance. They can stop using the alternative contraceptive methods, but the follow-up should be for 3 years. Everything will be there when you revise the whole recordings in the YouTube. Okay.
Thank you, Mr. Dansekar.
Yeah, and one other last thing. So that article is BJUI 1990. The one last thing is If the sperm specimens persistently has live sperms 12 weeks, 16 weeks, 24 weeks, you can't wait for 7 months. Okay, that's a different thing. You brought the 7 months criteria from special clearance into the normal follow-up. That's not so. The normal follow-up, if the patient has persistent live sperms 12 weeks, 16 weeks, 24 weeks, you need to make a honest talk with the patient. I think it's not successful, and are you happy for a re-vasectomy? If prior patient had a local anesthesia vasectomy, maybe second time you may have to advise for general anesthesia vasectomy. You can't wait for 7 months. That will be too long. Okay.
Okay.
Yeah, I
Thank
can
you.
clearly understand you took the 7 months value from the Oxford special clearance and brought it here. That's good. Can we go for the next scenario?
Yes, please.
Okay. You have a patient who is attending your infertility clinic, and he is coming because he's not able to produce child with his partner. And how are you going to evaluate him? He's 29-year-old.
I prefer to see this gentleman in my infertility clinic with the partner to take focus history, examine him, and then some investigations. In the history, I would like to know whether they had continuous unprotected sexual intercourse for at least 12 months to confirm the definition of infertility. And I want to know whether he or his partner had any previous children from other relationship, and whether they have been using any contraceptives before this, and also his past history, including any history of undescended testes, any inguinal scrotal surgeries, any past history of mumps in the past, and his social history, taking any illicit drugs and using gym supplements, excessive steroids, and also his lifestyle habits like hot baths and using laptop for a long term, and whether he has any recent history of febrile illnesses. All these will be asked, and his past medical history, including diabetes, any other neurological problems, any cancer history, chemotherapy, any retroperitoneal surgeries, whether he has any other erectile dysfunction or any other ejaculatory dysfunctions. After this, I'll move on to the examination in the presence of chaperone with his consent. I will see his general condition, BMI status, development of secondary sexual characteristics, a local examination of the penis and the testis, mainly to look for the testicular size and consistency, any other abnormalities, any surgical scars visible, and also look any presence of varicocele.
Okay, history-wise, there is no positive findings. Examination-wise, is normal, well-built, no specific findings except two findings. His left side testis is smaller in size compared to right side, and he has dilated veins in the left spermatic cord.
So this suggests that this patient is having a left-sided varicocele. I would know the grade of varicocele. So depending on my examination, if it is visible or if it is palpable in breast, or if it is palpable only when he does Valsalva. So I want to know that, and I would like to have an ultrasound scan for him, in addition to the other investigations for subfertility, such as semen analysis and the hormones such as FSH, LH, and testosterone.
How will you grade this varicocele? You said that. Can you grade it?
Grading is done based on the Hudson classification. Grade 0 is subclinical diagnosis, and grade 1 is visible only when, palpable only when patient has a Valsalva maneuver. Grade 2 is palpable at rest, and grade 3 is visible.
Okay, so what do you mean by subclinical varicocele?
Patient doesn't have any symptoms, and you can't clinically demonstrate that, but the ultrasound can pick up a varicocele.
Okay, and you are sending this patient specimen for sperm analysis. What is the normal sperm analysis results?
The volume should be more than 1.5 milliliters, and the total count should be more than 39 million, and the concentration more than 15 million per milliliters, and the motility, the whole motility should be more than 40, and the progressive motility more than 32, and normal forms at least 4% they should have, and fructose is more than 13.
Okay, and how are you going to advise him before he gives his sample?
I would advise him that he should have abstinence for minimum of 3 days, maximum of 5 days, to 3 to 5 days. I would tell him to collect it in the container given by the lab without using any spermicides, any condom. I would advise him to avoid coitus interruptus as well. Ideally, it should be collected in the center, but if he collects at home, he should take it to the center within 30 to 60 minutes. If he takes from home, he should keep it in the shirt or trouser pocket close to his body temperature.
Why 3 days abstinence?
The important thing is the sperm volume, and also the maturation will take 3 days. So we need to have the maximum out of it to get a better diagnosis.
Okay, his sperm analysis reported as volume of 3.5 ml with concentration 9 million per ml, progressive motility of 22%, sperm morphology 2.5% normal, pH 7.4, seminal fructose 16 micromole per deciliter. Otherwise, gonadotropin values like FSH is 10, LH is 6, testosterone is 15.
Okay, so he is having a normal volume sperm, and his pH is normal, fructose value is normal, his blood count, the hormones also normal. What I notice here is he's suffering from oligoasteroteratospermia, which is called the OAT syndrome.
Okay, so how are you going to do for him for his infertility?
This could be due to his varicocele, because we have evidence, we have latest evidence that if the patient has abnormal semen parameters, the treatment with varicocele is justified. His sperm count is less than 10 million, so I would like to have a few other tests for him from the start, such as karyotyping, microdeletion, and blood for CFTR gene mutation. I would plan to treat his varicocele, as I said earlier, that we have evidence now from latest Cochrane review, and also it has been given in the guidelines such as EA guidelines and AU guidelines. But I'm aware that a NICE guideline doesn't recommend, but now we have enough evidence to treat his varicocele.
Okay, what do you mean by the microdeletion?
Why microdeletion is, we have three types. The type A, B, and C. It is the deletion of Y chromosome. It depends on whether it's a proximal or middle part of the distal part. The importance of that is, if we are planning for an assisted reproductive technique, there's no point of doing in Y microdeletion type A and B, because there won't be any sperms. If it is type C, there's a 50% chance of retrieving sperm in micro-TESE. So to know this is important, considering his future management of his infertility.
Okay, good. Now, how are you going to proceed with him?
Yeah, I will proceed with the varicocele treatment. I would give him the options. It could be the minimally invasive technique by the interventional radiologist by the varicocele embolization. The other method is microsurgical technique, which has a better success rate. The other options would be, which is less favorable options in terms of recurrence, like open varicocele ligation or laparoscopic varicocele ligation. So in my practice, I would counsel them for the varicocele embolization by the interventional radiologist.
So how is it done?
It is done in the radiology suite. The cannulation done from the femoral vessels, and the pempiniform plexus access to the femoral vessels, and by metal coils, the dilated veins are obliterated. So patient will have the varicocele treated by that method.
Why left varicocele is more common than the right?
There are certain theories. One is the left testicular vein drains to the left renal vein compared to the right side, which is draining to the inferior vena cava. So this drains at a right angle, and also the valves are less in the left side. So those are the reasons.
Okay, so how are you going to follow him up?
I would see him in 3 months after the treatment of varicocele, re-examine him, and I would like to have another CML analysis after 3 months to see the improvement in parameters.
Okay, And after hearing the pros and cons, he didn't want the radiological ablation because of the metal coils you mentioned. So what's the next option for him?
The next option is microsurgical. So this is an open surgery. It's a subinguinal microsurgical varicocele ligation. So what we do is we do an inguinal incision. Under microscope, we'll see the dilated veins and then ligate them.
Why you are selecting microsurgery, subinguinal site?
We can ligate as many as veins possible, and by microsurgical is we have the extra clarity in the enlarged focused field. So the benefit of that is the recurrence rate is less than 1.5%, and it has more success than compared to the other methods.
Okay, what are all the disadvantages or side effects of microsurgery varicocele ablation?
Compared to if I compare to the embolization method, there's a small risk of hydrocele formation and also a testicular atrophy. Again, a small risk of testicular atrophy is there.
Okay, good. Well done, nice presentation. Especially I like the opening gambit. You have tried to cover everything. That opening gambit is very useful, not only in the subfertility due to varicocele. You can use it even for obstructive azoospermia and various other possible scenarios. Just two feedbacks for the previous first presentation I forgot to mention. You need to mention Bow's information guidelines whenever you are asking the patient to give sperm and sample for analysis first time. And second thing is, in the first scenario, 3 days abstinence is maintained. It is not for post vasectomy follow-up. Post vasectomy, we are expecting azoospermia, so there is no real reason for 3 days abstinence. Normally, say for example in the second scenario, the reason why we are doing 3 days abstinence is historically the studies were done without abstinence, patient having sex maybe overnight and then giving a sample, 1 day abstinence, 2 day abstinence, 3 day abstinence, 5 day abstinence, 1 week abstinence. There is a good spectrum noted. Say for example, if the patient presented immediately after sexual intercourse, if they ejaculate again, the sperm quality is low, volume is low, concentration is low. If they had an abstinence of 5 days, 7 days, more than 7 days, 10 days, the volume is increasing and also the number of sperms increasing. So no way we can ascertain which is the normal sperm parameters. So WHO has decided, let us take a cutoff of 3 days. So there is a reason why we are doing it 3 days, because internationally they have found the normal sperm samples at 3 days post abstinence and taken it as a reference value, so that it's standardized and we can advise all the patients to have 3 days abstinence. So it's nice if you know the reason why it is 3 days abstinence. And you mentioned about the 12 months of unprotected sex of WHO. In fact, that criteria was released in 2020. Try to get the correct age or year of the publication, because this publication years changes every time. Grade 2 varicocele is the varicocele found when the patient is standing, not rest. Okay. So grade 2 is varicocele present in standing. So grade 0, you are correct, subclinical, present only in ultrasound. Grade 1 is palpable only during Valsalva. Grade 2 is palpable when standing, not rest. Grade 3 is palpable on standing and it's visible on standing. Even without touching, you can see visible on standing. And why microdeletion? Just be careful. There are some references which said only for type A, there is no point in surgical sperm retrieval because you can't find any sperms, while B and C you can do surgical sperm retrieval. Just make sure you are getting appropriate references. I understand there are different references saying different things. Again, you need to mention about the Bow's information leaflet, either when the patient is going for radiological varicocele embolization or subinguinal microscopic surgery. Both ways we have separate leaflets. Okay?
Yeah.
Good. Can we go?
One thing, Mr. D, like the special clearance, actually, we had this confusion when we prepared. The Bow's information leaflet says 100,000. The constant paper says 10,000. Actually, I went through the paper as well. I don't know which one to take.
No, the paper clearly says it's 10,000.
I have gone through that paper, yes.
Yeah, I have the paper in front of me. It will be available in the YouTube once I load. So between 1980.
We'll go by 10,000, isn't it?
Yeah. That is the reference from which the paper is, from the Bowes information leaflet is prepared, isn't it? This is the only evidence. In fact, they have quoting a lot of areas, Constant's paper. And so the study was done between 1980 to 1985, where 6,067 patients were recruited. And they have clearly said that less than 10,000 sperms per ml, 2 consecutive examined samples, and at least 7 months after vasectomy. And these patients should be followed up minimum for 3 years.
Yeah, okay, brilliant. Thank you.
Okay. It's better to quote the correct original reference rather than the product of the reference. Yeah.
Okay, brilliant. Thank you.
Okay, can we go for the next scenario?
Yeah, we can. Thank you so much.
Okay, good. Your time starts now. You have a 32-year-old gentleman presenting to your infertility clinic. Obviously, the patient GP's letter says, please review this patient for infertility treatment. What are you going to do?
So I'll see him in the urology clinic along with his partner. I'll make sure that the couple has had at least 1 year of unprotected regular intercourse. I'll see if there are any, if it is a primary or a secondary infertility. We'll go through the history to see if he has any other risk factors, like any lifestyle factors of smoking, any alcohol intake, any use of prolonged sauna bath, use of laptops very frequently. In the medical history, mainly to see whether he's already on any medications, and also to go through the medical history to see if he had any previous medication, chemotherapy, or any radiotherapy to the pelvis, any previous inguinoscrotal surgeries, any lower abdominal surgeries. This will be followed by I'll move on to the examination. I will do this in the presence of a chaperone. I'll mainly look to see his BMI, performance status, and also any secondary sexual characteristics, any regarding the body hair composition, like that. I'll have a focused examination of the external genitalia, external meatus. I'll examine the testes to see the presence, consistency, and any abnormalities of the testes. I'll also positively look for both vas deferences, whether it is present or not, and also any presence of varicocele. And yeah, so that will be my initial approach to him.
Okay, examination wise, everything is normal. There is no specific findings noted. What is your next step?
So he hasn't had any semen analysis according to the GP referral letter. So first of all, I'll tell the couple that we have to have at least 2 semen analyses 3 months apart, and they have to make sure that the semen analysis collected after 3 days of abstinence and delivered to the facility promptly and with all the instructions. I'll give them the Bowes information leaflet on how to collect the semen sample, and we'll refer them to the local fertility center for the semen analysis to be done.
Okay, the semen analysis showed azoospermia. So what may be the reasons?
So azoospermia could be obstructive or non-obstructive azoospermia. So it starts from the clinical examination and the history. If the clinical examination shows a presence of small testes, and also if there are any secondary sexual absence of secondary sexual characters, and also if there are any features of Klinefelter syndrome, then we have to think about non-obstructive azoospermia. If it is like the semen sample, then the second thing is that semen sample. If it is a low volume semen, depending on the pH and the volume of the semen, we can say whether it is a obstructive azoospermia, and we can at least predict the type of obstruction depending on the pH and the volume of the semen. So I'll be looking onto the other parameters like the pH of the semen, the volume of the semen, and the fructose of the semen sample.
Okay, what do you mean by Klinefelter syndrome?
Klinefelter syndrome is a genetic syndrome that is caused by, it is a reason for primary testicular failure. In this patients, there is a chromosomal defect 47XXY, So because of that chromosomal defect, the patient has got small testes, and this will cause primary testicular failure. So in these patients, clinically, these patients are they have got a height more than the normal for the population, and they have got widely spaced, gynecomastia, and these patients will also show, when we look into the hormonal parameters, it will show increased FSH and LH, and so these are the characteristics of Klinefelter syndrome. These patients will usually present with infertility. 70% of them will present with infertility, and these patients are also at risk of developing testicular tumors.
Okay, the sperm analysis shows absence of sperms, absence of fructose, very consistent with obstructive azoospermia. So what are you going to do?
Absence of sperm and absence of fructose. Okay. May I know what's the pH of the?
pH is not mentioned.
Not mentioned. Okay. So
what is the importance of pH?
So if it is an acidic pH, then that means that it is a prostatic secretions coming. So there is no seminal vesicle fluid coming out. So in that case, it could be ejaculatory duct obstruction.
Okay, so take it as an acidic pH then.
Yeah. So in that case, I have to think about low pH, low volume semen, and absence of fructose. So it is more and if the testicular size is normal, then that is more suggestive of ejaculatory duct obstruction. So during my examination, initially in that case, I had to do a truss volume of the transrectal ultrasound scan to see if there is any midline cyst or if there is any ejaculatory duct dilatation. Okay,
so this is the truss picture.
Yeah, so this is a transverse image of the transrectal ultrasound, which clearly shows a midline cyst, which is suggestive of ejaculatory duct cyst, and this could be the cause for the ejaculatory duct obstruction. So this means that this is a azoospermia due to distal obstruction. And in my examination, it will correlate, like it will be normal testis, and the epidermis will be normal, and vas difference will be present on both sides. So I will go ahead with the management of ejaculatory duct obstruction. So I'll tell the patient that there is an obstruction to the outflow of his semen near the water pipe, near the urethra. Normally, what we do is it's a combined procedure by the radiologist and the surgeon. It involves the radiologist injecting a methylene blue dye. Initially, it involves an aspiration of the seminal fluid from the cyst, and then looking for the presence of sperms. If there are sperms in the seminal fluid, then the radiologist will inject a methylene blue dye into the ejaculatory duct cyst, and then the urologist will do the transurethral resection of ejaculatory duct, TURED. This procedure carries slight risk of incontinence and retrograde ejaculation. Also, it can cause chemical epididymitis, and sometimes it can even adversely affect the fertility rate. And the pregnancy rate after having the TURED procedure is around 30%. So I'll tell all these risk factors to him, and if he is willing to go ahead, then I'll list him for TURED and inform the radiology team as well.
Okay, you're doing TURED, as you said, initially transrectal aspiration done, which showed presence of sperms, and methylene blue is injected, and TURED showed the methylene blue is getting oozing out, and plenty of sperms got expelled from the cyst, and good hemostasis attained. Why you said there is a possibility of retrograde ejaculation?
So if there is with the resection, any procedure in the prostatic urethra carries slight risk of retrograde ejaculation, especially depending on the length of the prostatic urethra, and also because he is young, doing the resection, if you are not careful, then that can damage the bladder neck as well.
Okay, so what are you going to do?
So because we have done the TURED, our aim is to go ahead with the natural conception method. So we will encourage the patient to continue with the natural conception method and see if he can father a child.
Why you didn't consider saving the sperms when you're doing the TURED?
I'm sorry, Mr. D, I couldn't hear
No,
that.
why you didn't consider saving the sperms which are coming out when you are doing TURED?
Yeah, sorry, I should have mentioned that during the initial aspiration from the seminal cyst, if there is presence of sperms, we will send that for cryopreservation, so that if the patient cannot father a child by the natural methods, we can use that for the assisted reproductive techniques.
Okay, if you have to send the sperm for cryopreservation, either by aspiration or when you're doing TURED, taking out the specimens coming out through your cystoscope, what preparations you need to make for that?
So we have to have a buffered solution for the preservation of sperm. We have to send it for, we have to have a geneticist present to confirm the presence of the sperms, and also for the method of cryopreservation.
Okay, good. That's very nice presentation, and like the last scenario, smooth flow, all the three scenarios today were discussed very nicely in detail, because the scenarios were not much in detail. There is only 3 or 4 pages for every scenario, so once you read everything, you read everything, that's it. The only thing is none of you mentioned about orchidometer. So in these kind of andrology infertility scenarios, nice to bring the orchidometer so that you are getting the baseline size of the testes, because things may change after vasectomy due to vasal artery injury or some problems. Testes can go for atrophy. After microsurgery also, sometimes testes can go for atrophy. So it's nice to bring the orchidometer in the examination, especially in this table, whether it's andrology or infertility. And regarding TURED, retrograde ejaculation, I'm not much interested in that. I don't think it is correct by mechanism. Maybe you can say an ejaculation, almost as similar to injury to the ejaculatory duct. Patient may be already having an ejaculation, so it may not be a new side effect for him. Of course, incontinence is acceptable because it's quite close to the sphincter. And you need to send the blood samples for HIV and HPSAG to with a preparation for cryopreservation. So patient should have virology screening done. So on the whole, you completely missed that cryopreservation part of it. It's nice to have it done along with TURED, because there is a small possibility the sperm aspiration and TURED specimen are the only specimens. That's it. Then patient will be anejaculate and azoospermic throughout the life. So that's a very, very, very valuable specimen. So don't miss that. And genetist and genetic specialist is not a bad terminology, but the usual terminology is embryologist, which is much more commonly used in UK. Nothing wrong in it, but the better terminology, better sounding is maybe embryologist. Okay, good. Can we go for the fourth scenario?
Yes, Mr. Dashikru.
Okay, your time starts now. You are hearing all the three scenarios. The patient who had the vasectomy in the first scenario, unfortunately, after 5 years, he fall apart with his partner, and he is presenting with you for vasectomy reversal. How are you going to counsel him?
I'm sorry, I didn't catch the first part. Can I know the age of the patient?
Now the patient's age is 38.
Right. So I will review this patient in my andrology clinic, ideally in the presence of his partner. I will review his latest sperm count, and I will go ahead and review his other symptoms, including any pain in the testes that he may have, and any problems in erection or ejaculation. I'll then confirm his past medical history, his ASA status, any prior surgeries apart to this that he may have had, and then I'll proceed with examining him in the presence of a chaperone after taking consent, where I'll examine him. I'll first do a general examination, look at his observations and body mass index. I'll do a examination of the abdomen, look for any scars, any apart from the scars of the vasectomy, which I'm expecting, I'll palpate for the scars of the vasectomy to see what I can find there, and I'll palpate the testes to see if their volume is correct. I'll use a Prados oculometer as a reference here. That should complete my examination, and then I'll proceed with investigations. Since this patient wants a vasectomy reversal, I'll first start with getting a semen analysis if he has not had one already. And then, depending upon the results of the semen analysis, I'll then counsel him about his future options. Before proceeding any further, I would like to evaluate his partner as well and see if see the age of the partner. Apart from this, if a partner has any other known problems with fertility, see the number of children that her partner has had previously with any other partner, and the number of children that the patient wants at the moment, if it is one or more than one patient. Further, I would also like to take some social history from the patient, wherein I want to see how his finances are, because this procedure will not be funded by the NHS and even private insurance. So I'll wait for the semen analysis and then proceed ahead.
Okay, he has 3 children in the past before his vasectomy, and his partner had 1 child. And the reason for the vasectomy reversal is, unfortunately, he split from his previous partner and now he's got a new partner. His new partner age is 22, normal menstrual cycle, and they sincerely wish to have 1 more child of their own. And he is aware of the non-availability in NHS, and he's happy to pay from his pocket for private service. How are you going to take it forward?
So now that I have this information, his partner's age is less than 40, and I'm sorry, I would also like to know the number of children he wants. Is it more than 1?
Yeah, possibly.
Okay, so I'll and the time since vasectomy is 5 years. So I will explain to him that with these parameters, there is a 50 to 60% chance that with vasectomy reversal, we would be able to achieve pregnancy rates. And overall, this is the more cost-effective option. But I would also explain to him that the other option of assisted reproductive techniques is available. I would explain the pros and cons of both these options. And then, depending upon what he decides, I will go ahead and discuss what he wants.
So what is the patency rate and pregnancy rate post vasectomy reversal?
So this depends upon the duration from the vasectomy. So if the duration is less than 3 years, then the pregnancy rate is 75% and the patency rate is around 90%. If it's 3 to 7 years, then the pregnancy rate is around 70% and the patency rate is around 60%. If it's 7 to 15 years, then the pregnancy rate is around it's around 50%. And if it's more than 15 years, then the pregnancy rate would be around 30%.
Okay. Now he's happy with the rates you're quoting, and he's happy to give a good go for vasectomy reversal. So how are you going to proceed?
So I will again give him, I'll counsel him about the procedure. I'll give him the BOUS information leaflet. I will explain to him that the procedure, the aim of the procedure is to attain, bring the 2 ends of the vase together. I will also, just on examination, I would have had an idea whether I'm going to have to do vasoepidymostomy on any of the sides because of the distance of the scar from the epidymis. So once I've told him all this, then I will tell him that at the end, on that day, we may have to do a vasoepidymostomy instead of vasovasostomy. Depends upon what we find there. I've already quoted to him the success rates that are possible. Then I'll tell him about the procedure and the possible complications, which would include risk of hematoma, risk of infection in the area. And apart from this, it would also include risk of failure, which I've already explained to him. These are the common risk, the problems that I'll tell him. Apart from this, there is a possibility of chronic testicular pain. At this stage, I would send his viral screen because we might have to preserve his sperm. We will have to preserve his sperm, whatever we are able to get from the proximal end of the vase. On the day of the procedure, if he's happy to proceed, Then I will organize this procedure to be done under general anesthesia. I will have him in the after I've adequately counseled and consented him, I'll do the WHO checklist, sign in and timeout, and then I'll proceed with bilateral transverse total incisions under general anesthesia. I will be using a surgical microscope, and I'll make sure that the radiographer is also in the room with the C-arm, because I may have to do a vasography. Now, once I've made the transverse total incision, then I will dissect out the ends of the sperm. I will freely mobilize it enough so that two ends of the vase are coming close to each other. Then I will hold the two ends of the vase in the vasectomy reversal clamp. Then on the proximal side, I'll make a cut and on the scrotal side, on the testicular side, I'm sorry, and see the type of fluid that is coming. Now, if it is copious and clear, then I'm happy, and I'll have this checked by the embryologist. And if they tell me that there are sperm present in this, then I'll be happy to proceed. However, if there's no fluid, then I can wash it with the angiocatheter. If there is a debris there, then again I'll have to keep cutting proximally until I can find clear copious fluid, and the embryologist tells me that there are sperm in the specimen. Then I will collect some sperm and give it to the embryologist in a buffered solution for cryopreservation. Once I've done this, then I can do this procedure by the micro-dot two-layer technique, wherein using the surgical microscope, I'll make 6 dots at 12 o'clock, 6 o'clock, 2 o'clock, 4 o'clock, 10 o'clock, and 8 o'clock position. And I'll be using 10 proline sutures to do a two-layered anastomosis. I have to make sure that there's precise approximation and there has been no extensive dissection of the peri-adventitial layers. Once I've done this, I'll close the layers, and I will then I'll finish the procedure. I'll repeat the procedure on the other side, and that'll be all. I'll close the procedure, and I'll be happy to ship the patient to recovery.
So in which situations you will need a C-arm?
So if there is a suspicion of distal obstruction, then I will need a C-arm. If I'm having to do a vasography, for instance, if this patient has had any other inguinal procedure as well, then I would like to do a vasography to confirm there's no obstruction on the opposite side, apart from the testicular side.
Okay. If you have to anastomose vas into epididymis, what is your plan?
So if I have to anastomose the vas into the epididymis, then I'll use one of the loops of the vas and make a cut into it. And again, I'll collect the fluid that comes out. And once the embryologist can confirm that there's sperm, I'm happy to proceed. I'll anastomose it using the interception technique and use that loop of vas to do a vasoepidymostomy.
Okay, so which part of epididymis you will use for anastomosis?
So I'll prefer to use the tail, and again, if there's no sperm in the tail, then I'll keep proceeding to the body and the head, but I would prefer to use the tail, as pregnancy rates and patency rates are much higher on that side, with the tail.
Why it is high with the tail compared to the caput?
It is because the sperm gain their motility in the tail of the epididymis, and we might be able to find more motile sperm in the tail of the epididymis.
Okay, good. Again, very nice presentation, very standard scenario. So there is no room for failure and any mistakes also. And you did very good. The few small things here and there I can add is the reason why we are tweaking it in the tail is as the sperm is moving in the epididymis, it gets matured also. So you will get a better mature sperms in the tail compared to the caput or the body of the epididymis. That's why you prefer the tail. And in the examination itself, you can see that where is the previous vasectomy site just by palpation, because sometimes it may be quite close to the epididymis. That can pre-warn you or the patient also about the possible vasostomy. And you covered Bow's information, you covered C-arm, that's good. But you covered C-arm, but you haven't brought it into the discussion. So try to bring it to the discussion that if I need, I will do an intraoperative vasogram. And you can also use O nylon suture to see for the patency in case if you don't have C-arm. That's another nice method to mention. And the sutures 10-0, it should be like inside out, so that the sutures are present outside and inside not are present outside. Those are all the small things you can mention. You can stabilize the both ends of the vase in a non-tension manner by using a 4-0 suture, so that that keeps it quite in a relaxed non-tension procedure. Of course, you mentioned about the vasectomy reversal clamp. That's a equally good one. So there are small things. Maybe it's nice to know at least, but performance-wise, I think today all four of you did very well. Very nice coverage of the scenarios, and good. This is how it has to be few days before the exam, isn't it?
Yes, Mr. Danish.
Good. Any overall questions before we conclude?
Yeah, Mr. D. Regarding the reconstruction part, so we have to do the fluoroscopy in all cases, isn't it? In all cases of reconstruction?
Not necessary. Only if there is any doubt. It's nice to do because it won't cost much time. Because you should confirm patency both proximal and distal. Regarding the distal patency from the testes, the sperm ejaculate itself is more than enough for you. But for the proximal, it's nice to do like a template. It's like, for us, it may be quite unusual for a urologist doing an RGP before ureteroscopy is very normal, isn't it? So for the routine infertility practitioner, andrologist, surgeon, it may be quite routine for them to just do a proximal vasography to make sure the patency is fine before doing the procedure, because it's a very lengthy, time-consuming, costly procedure. We don't want to anastomose and find there is another obstruction in the proximal vas.
Perfect. Thank you.
Mr. Dhanasekaran, I think you already answered regarding this special clearance number. I think in meanwhile I went through both Oxford paper as well as the Bowes consent form. The original Oxford paper says exactly what you said. That is 10,000 and to ejaculate after 7 months. Although there is maybe a typo mistake or a Bowes hasn't got that number. They have mentioned 100,000, and even the Viva book has all mentioned the less than 100,000. So I think we should stick to the original paper, isn't it?
I think so. In the YouTube, when you are revising it, I will give a kind of a screenshot of the original 1990 British Journal of Urology paper, and it clearly mentions less than 100,000 sperms per ml, 2 consecutive samples. And as long as you are quoting that article, your answer is correct.
Excellent. Thank you. Thank you so much.
Good. Okay, guys. Best wishes. If there is no other questions, can we conclude?
Yes.
Good.
Thanks so much. That was an excellent session. Thank you.
Yeah, we have really covered all the rare scenarios. None of us are expert, definitely including me. I'm not an expert in this. And so tomorrow we are planning to do male LUTS. That's what you guys want, isn't it? BPH?
Yeah.
Okay. So 6 o'clock tomorrow. Let's have the next session. Thank you for joining. Wishing you all good evening. Bye.
Thank you, Mr. D. Thank you.